Hi everyone, I wanted to just record these lectures just in case I don't get through all the material, and then you'll have them to go back over and listen to as needed. So the first one is thyroid disorders. The objectives are to explain the function of the thyroid gland and associated hormones, recognize signs and symptoms of undiagnosed hypo and hyperthyroidism, identify treatment options for both hypo and hypothyroidism. So the endocrine system as a whole is a collection of glands that produce various hormones that do all sorts of stuff in the body. They regulate metabolism, they regulate growth, development, tissue function, sexual function, sleep, mood, all kinds of stuff. So hormones are produced by glands, and then they're kind of sent off into the bloodstream to all different various tissues in the body to perform some kind of an effect on the body. They send signals to those tissues and tell them what they're supposed to do and how much to do it, that sort of thing. And then when the glands don't produce the right amount of hormone, then it's going to cause some kind of a problem. Usually some kind of a disease develops that can affect so many aspects of life. I mean, you can see all the ways that really major important things, our sleep, for instance, is huge. So if there's something going on and disrupting somebody's ability to have regular sleep patterns or regulate their heart rate or something like that, then you can see it can be quite disturbing into somebody's life. So the thyroid function, the thyroid gland is located in the front of the front of the throat, down low, right below the Adam's apple, in the kind of the lower part of the throat. It's very difficult to feel unless something is wrong, unless it's like swollen, and then it's very easy to feel. But we always feel for the thyroid gland, but really it's almost like, well, what are we feeling? Well, probably not feeling very much, but that's a good thing. The thyroid gland is super important because it regulates something called basal metabolic rate, which is basically the baseline speed at which your cells perform whatever specific function. And some of those functions are metabolizing carbohydrates, proteins, and fats, maintaining blood pressure, and then regulating growth and development. So it's a pretty important gland. So the thyroid gland produces two major hormones that we'll talk about. T4 is secreted, or T4 or thyroxine is secreted from and then it's synthesized at various target tissues in the body, and predominantly the liver. It's synthesized into T3 or iodothyronine. So that is the active form of T4. So first you have T4, it's then synthesized into T3, which is now the active form of the thyroid that actually is going to do the stuff in the body that we want it to do. Oops, sorry. Let me back up. So T4 has very little effect on metabolic rate. It can be floating around the body and may have a very, very small effect, but really T3 is what's active. So here, the slide we have, it's the major hormone secreted by the thyroid gland is T4, but it's going to be synthesized into T3 at the target tissue, and then it's going to enter the target cells, bind to these receptors, these intracellular receptors, and then it's going to become its active form and then play out its function. So a couple more things about these hormones. 87% of T3 is going to be synthesized from T4, and then the remaining 13% is going to be synthesized by the thyroid gland itself. Now, in order to make synthesize T4 into T3, we need iodine. So we have to have iodine in order to make this conversion, or for T4 to change into T3. And where do we get that iodine? We predominantly get that iodine through our dietary iodized salt, which begs the question, where did we get it before we were putting iodine in salt? I'd just love to dig into that one a little bit. But that's predominantly where we get our iodine, and that's why we don't see a lot of diseases that come from this lack of dietary iodine, because we have iodized salt and we eat a lot of salt in our country. So we don't usually see the diseases that stem from a lack of that, like some other countries that may not actually have regular iodized salt readily available. So once the thyroid hormones make it into the blood, they can either be, so we're down here at this bullet point, once they make it into the blood, they can either be free-floating, just like when we were talking about the drugs that get into the bloodstream, they can either be just free-floating or they can be bound down to protein. Thyroid hormones are highly, highly, highly protein-bound hormones. So almost all of it is going to be bound up into protein. So 99.9% of T4 and 99.5% of T3. So that tells you that you really only need a tiny bit, because what is free floating is active hormone. And so obviously a little bit goes a very long way. A little thyroid hormone goes a very, very long way. And as the body kind of uses that free floating thyroid hormone, some of the bound thyroid hormone can become unbound and become usable. But obviously we don't need very much to have a big impact. So how does the body know how much thyroid hormone is needed? The hypothalamus makes a hormone called thyroid stimulating hormone. And so this is what you'll see written a lot as TSH. And TSH secretion starts something called a negative feedback loop. And it's just in constant communication with the thyroid. So what's a negative feedback loop mean? The negative feedback basically means that when the thyroid stimulating hormone starts to decline as the blood level of T4 rises. So it kind of is like this self-checking thing. TSH is released, stimulates the hormone to make T4. Enough T4 comes out into the blood, and the hypothalamus kind of goes, oh, okay, we got enough for now. And then once it starts figuring out that the levels are dropping, then it goes, oh, I better produce some TSH. And so then it kind of starts to secrete again. So it just kind of keeps this constant check on the levels of T4 to know, how much it needs to do. So it's a constant loop of increasing levels and then decreasing the secretion when the levels are up. So it's just this constant, and you can see it in the picture here. From the hypothalamus to the pituitary gland, sends it out, produces the T4, blood levels go up. So it says, oh, you can back off, but then once the levels drop again, it's going to start producing the TSH. So talking about thyroid disorders, we have two main disorders. You can either be hyperthyroid, which means that you have increased serum T4 levels and decreased serum TSH levels, or you can be hypothyroid, which means you have low T4 levels but high TSH levels. So you can think about that kind of in the way that you're thinking. You can help it relate you back to that negative feedback. If there's lots and lots of T4, you're not going to have a lot of TSH, and vice versa. So that's why when they are testing and they see that you're hypothyroid, they say, oh, you have a lot of T4 but hardly any TSH because you've been producing so much T4. So blood tests are the typical way in which thyroid disorders are diagnosed. The blood test measures the amount of unbound T4 and TSH levels in the blood. Because of the negative feedback loop, if a patient has hyperthyroid, they would have increased levels of T4, decreased levels of TSH, and the opposite for hypothyroid, like we already said. So here's an image of a goiter, the very enlarged thyroid, super enlarged thyroid. The gland is enlarged, it's inflamed, and this can be a result of either hypo or hyperthyroidism. Insufficient hormone production can make the gland enlarged, so if it's hypo, it can be enlarged, most commonly caused by not enough dietary iodine. So you usually see this sort of a enlarged gland in areas that don't have that dietary iodized salt. So this is really rare in the US. Another cause, though, that can create an inflamed or an enlarged thyroid is an autoimmune condition called Hashimoto's disease. And in Hashimoto's, thyroid is underactive, and an enlarged thyroid can also be from a cancerous tumor. So it can be from several different things, but a lot of times in certain areas of the world, you'll see that because of the lack of dietary iodine. So the etiology of hyperthyroidism, so the most common type of hyperthyroidism is an autoimmune condition called Graves' disease. With Graves' disease, the body has produced antibodies against its own organ. So it's produced antibodies against the thyroid and it starts to destroy it. So when a person is experiencing hyperthyroidism, they will often feel super sweaty and nervous and sensitive to heat, fast heart rate. They may also have weight loss, and with Graves' disease they may have the bulging eyes, and that is from inflammation and buildup of tissue behind the eyes. So the body is just kind of attacking that area behind the eyes as well, and so you get sort of a buildup of the muscle starts to go away, and they get a buildup of fatty tissue behind the eye. So here's another image of hypothyroidism. So when the immune system attacks the tissue around the eyes, it causes the eye muscles or the fat to expand, and the bulging is a result of inflammation and a buildup of, I keep saying the same thing, a buildup of the fatty tissue behind the eyeball. Okay, so treatment for hyperthyroidism. So how is hyperthyroidism treated? So there's a couple different drug treatments. There's thiamide drugs inhibit the production of thyroid hormones. So when you have an overactive thyroid, if you take a thiamide drug, it's going to inhibit the production of thyroid hormones. Another very common treatment route is radioactive iodine. So this is given to a patient and it will typically destroy the entire thyroid gland, leaving the patient in a hypothyroid state. So now they're going to go from hyperthyroid to being hypothyroid because they've essentially destroyed the gland. If this is the treatment, if the radioactive iodine is the treatment that is used, then the patient typically will at this point have to go on thyroid supplements for the rest of their life because now they're hypothyroid. So another hyperthyroid treatment is something called a Lugols solution. It's a 10% potassium iodine and 5%, I think this is supposed to be iodide. It's 10% potassium iodide and 5% iodine. This is also used in something called a thyroid storm, which is very serious, life-threatening condition where they have been hyperthyroid for a long period of time, and now they're having some major system reactions. It's called thyroid storm or thyrotoxic crisis. And this would be super rare if you saw a patient in your dental chair who was actually going through or was experiencing thyroid storm. But if for some crazy reason it happened, epinephrine is strictly contraindicated. But like I said, it would be incredibly rare to have somebody in your chair and needing to be anesthetized with local anesthetic. People who are experiencing thyroid storm are probably so sick they've brought themselves to the hospital because it's life-threatening. But back to the Lugols solution, this is an over-the-counter solution as well. It's not a prescription, but there have been some restrictions on the amount of the concentration of this solution, because I guess people have used it for other things in the production of methamphetamines and things. So, but it is an over-the-counter solution. So the etiology of hypothyroidism is a deficiency. So hyper is too much, hypo, too little, deficiency in the secretion of T4 and T3 from the thyroid gland. And then, of course, with that, you'd have elevated levels of the serum levels of TSH, because the body's trying to say, hey, we need more thyroid, hormone, but it's not happening. So this is more common to happen in women, and signs and symptoms, if it's undiagnosed, tends to be so the opposite of everything's running hot and fast, everything's kind of slow and cold. So cold intolerance, weakness, tired, fatigue, hoarseness, chest pains. And then I think it's pronounced myxedema. Myxedema is another term for severely advanced hypothyroidism, and that's spelled MYXEDEMA. And this is mostly seen usually in older patients. So treatment for hypothyroidism is it's called Thyroid USP or ARMOR, and this is not as common. Thyroid USP can cause allergic reactions because it's a bovine, or I think it's from a pig, actually. And it's either from a pig or a cow, or maybe it's both, but it's thyroid hormones sourced from an animal, and so it has a tendency not to work so well with humans and cause more allergic reactions. So the one that you'll see a lot on patients' medical history is Synthroid or levothyroxine. That's a very common medication that you'll see. And so this is for therapeutic purposes. It's synthetic T4, and it's used because it's easier to keep this at this constant blood level to achieve the turnover into T3. It has a half-life of 7 days as opposed to T3, which only has a half-life of 1 day. So you can take the T4 and then your body can do with it what it needs. So hypothyroidism, if somebody is if their dose of medication is too high, they can form congestive heart failure, which of course is super dangerous. So it can cause congestive heart failure and fluid retention around the heart. So that's the dosing of supplement thyroid hormone is super important to get just right. And patients usually need to have their blood tested and make sure that they're dialed in to just where they need to be. So this is an image of a little girl that you can see before she started treatment. She's hypothyroid before she started treatment and after. And some things that can happen when somebody's hypothyroid and hasn't had treatment is they can have swelling in their face, and they can have sort of a color change as well, like their skin can have kind of a yellowy effect, but they'll have that sort of a moon face or a swollen face, and then you can tell after they started treatment that that swelling has gone down. So some important things to note: there are no special precautions. If you have a patient in your chair who is has a overactive or underactive thyroid, if they're well maintained, there's really not much you have to be concerned with. If you're unsure if your patient is stable, or if the patient doesn't know if they're stable, or they say, I've been having trouble stabilizing my medications, then it's prudent to have a medical consult before administering local anesthetic. Usually you can, if it's just 1 or 2 cartridges, it's not a big deal. It's even if someone's hyperthyroid, but it never, ever, ever hurts to have a medical consult if you're concerned. And then, like we said before, if somebody is in a thyroid storm, then you absolutely wouldn't use any local anesthetic with epinephrine, but you probably, hopefully, will never experience that. So not too much to have to worry about when you have a patient with thyroid disorder in your chair, but it's definitely important to know if they are well controlled and what they're taking the medication for.